Good afternoon and welcome to our Cardiac and Vascular Lecture Series. I am Dr. Khaled Hakim, Assistant Vice President of International Healthcare Partnerships and Insurance Development at Baptist Health International. It is my pleasure to welcome all of you to this informative presentation. I would like to extend warm greetings to our friends across Latin America, the Caribbean, and everyone joining us today. During this interactive presentation, you'll have the ability to ask questions via the Q&A feature located on the bottom of your screen. I will be your moderator in today's lecture. This afternoon, I have the distinct pleasure of introducing Dr. Marcus St. John. He will be presenting a lecture titled New Approaches and Techniques in Interventional Cardiology at Miami Cardiac and Vascular Institute. Dr. St. John is an interventional cardiologist and the medical director of the cardiac Cath at Baptist Health's Miami Cardiac and Vascular Institute. He is a board certified in cardiology, interventional cardiology, and nuclear cardiology. Dr. St. John was born in Grenada and grew up in Barbados. He received his undergraduate degree from Johns Hopkins University in Natural Sciences Public Health and was elected to be the Phi Beta Kappa Honor Society member. He earned his medical degree from Harvard Medical School. He completed a residency in internal medicine at Brigham and Women's Hospital, a teaching affiliate of Harvard Medical School, and completed a fellowship in cardiology and interventional cardiology at Johns Hopkins University. In addition to interventional cardiology, his interest includes general and preventive cardiovascular medicine. Dr. St. John is a principal investigator and co-investigator of several clinical research trials for heart disease. Dr. St. John was the first recipient of the Herbert Green Physician of the Year at Baptist Hospital. He is a board member of the Greater Miami and Fort Lauderdale American Heart Association and is a clinical assistant professor at the Herbert Wertheim College of Medicine at Florida International University. Let's give a warm welcome to Dr. Marcus St. John. Dr. St. John, what a pleasure having you once again with us. Thank you for joining us. You may share your presentation.
Thank you, Dr. Hakim. I appreciate the opportunity, and many thanks to everyone at the International Department at Baptist who made this possible. It takes a lot of effort, and I appreciate the chance. So as Dr. Hakim mentioned, I'm medical director of the cardiac Cath lab. I'm an interventional cardiologist, and I'm going to talk about the new approaches and techniques in interventional cardiology at MCVI. And we're going to focus not just on some of the things that we do in the Cath lab, but also the processes that bring to bear good care of interventional cardiology patients. And this is not intended to be an exhaustive recap of everything that's new in interventional cardiology, but sort of one or two things that we're excited about at MCVI. Let's see if I can advance my screen. This will be the first test of the IT process. Give me 1 second. So we talked about the overall goals and objectives for the talk. So we'll start with a case discussion, and this is the point in the talk. If we were live, or if it were a Zoom format that I could easily interact with the audience, I would have you answer some questions. But I'll sort of talk us through what the questions might be and what the answers are. And certainly at the end, we will have a chance with Dr. Hakim's help to do some Q&A. So a 53-year-old man presented to the hospital with the acute onset of chest pain within 2 hours of onset. And you see here his EKG. I know we have some students in the audience, so I would ask them what they thought of this. But what we see here is anteroseptal ST elevations. So ST elevations in the precordial leads, and with a little bit, although not much, reciprocal depressions in the inferior leads. So this gentleman was brought emergently to the Cath lab. So one of the things that we take for granted, certainly in most metropolitan areas in the US, is that we have 24/7 Cath lab coverage. So this was not a difficult decision. It didn't require a lot of phone calls. So we have a STEMI process. And with one phone call, the emergency department physician could get the operator on the line, and then he or she would call the entire team. And they didn't need to wait for conversation with anyone. We sort of got the call and came running. As is often the case, we'll take a picture of the artery that we think isn't the culprit vessel. So in his case, this is the right coronary artery, and I'll just show you that for those who are not used to looking at these things. And also here on the right, what we see importantly that the interventional and the general cardiologist will notice is he does have some collateral flow to the LAD, which is occluded, left anterior descending artery. This is the complete occlusion here of the LAD. Dr. Hakim, let me know if you're seeing my cursor, my pointer. Perfect, thank you. And we see that here again in this view. I appreciate that feedback. So this patient was done by my partner, Dr. Quesada. What we see here is a wire across the lesion, and already just with passing of the wire, we've opened that area of occlusion. And he does a little bit more work, and then a stent is placed here. That's what you can see vaguely here. But what we see, though, is clearly the artery is open and the crisis is averted. So the question then becomes, what else could be done for this gentleman, or what needs to be done next? So in most cases, we would proceed with guideline-directed medical therapy, and we have a lot of things that we know improve mortality and improve outcomes: aspirin, P2Y12 inhibitor therapy, high-intensity statin therapy for some people, PCSK9 therapy, beta blockers once they're not in shock or at high risk for shock, and then for most people, an ACE, an ARB, or an ARNI. And we won't have time to go into all of those potential options. But even with all of that, what we have seen is that despite the evolution of PCI as a treatment strategy, so it is a class 1 indication, getting people to the cath lab right away is how you best treat acute MIs in 2021. Despite that, we've seen a plateau in the rates of short and long-term mortality and heart failure. So we're not getting any better despite more than 2 decades now of this treatment. And the question is, well, why is that and what's holding us back? Before we get to that discussion, we can see here what his ventricle looks like. So definitely an anteroapical wall motion abnormality. And that's showed again here on the echocardiogram. And this is a DEFINITY contrast enhanced study. And the EF was estimated by echo as 43% at the time of his hospitalization. So this speaks to what I was talking about, sort of the plateauing of rates of heart failure and MI post-PCI. And I'm not suggesting by any stretch that PCI is not improving mortality. It has, and definitely has made a big difference. But despite evolution of PCI care, we're not gaining any more ground recently. And that suggests that there's still some unmet need for how we better improve things. And that is what we're going to discuss first of all. And that unmet need could be in the microvasculature. So what we saw just now was that we opened the stent, the epicardial artery, but we're not quite sure what was going on in the small vessels, the capillaries, the so-called microvasculature. And that's where the concept of supersaturated oxygen has recently come into play. So when we went from thrombolytic therapy only for treatment of acute MI, and that still is the primary treatment in many countries and a great treatment and one that you should continue to apply. When we went from thrombolytic therapy to PCI, we saw a 5% decrease in infarct reduction sites. So that is sort of a benchmark, as it were. So a new therapy should at least meet that criterion. And that is exactly what we're seeing with this new therapy, which I'll discuss here. This was from a recent ESC review paper, and the authors here discuss the fact that despite successful revascularization and restoration of blood flow in the main epicardial arteries in patients presenting with acute MI, perfusion to the coronary microvasculature is less successful. This phenomenon is termed many things. No reflow is a common term. Microvascular obstruction or coronary microvascular dysfunction are some of the others. And this is what we think is causing that plateau in the improvement of rates of heart failure and mortality, both in the short term and long term. It's sort of what's holding us back, because our treatments so far don't yet address the microvasculature very well. So this picture we've seen already. And the question is, what really is under the surface? What are we seeing? Are we only seeing the tip of the iceberg? And I like this image here because it shows us that, yes, when we see the epicardial arteries, that's great. And that flow is important and necessary. But beneath that is this vast, almost incomprehensibly enormous network of microvasculature. And if you think about these vessels being clogged or edematous or simply not functioning, you can easily appreciate why having an open artery in some patients is simply not enough. And we do have the room to make a great deal of improvement if we can improve the circulation in these vessels. And that's really where the focus of supersaturated oxygen and other emerging technologies is. This was an article that actually got published, I think literally online earlier this week. And I'm going to use it as a backdrop to support this conversation. I wanted to point out that some of the authors are really some of the heavy hitters in interventional cardiology. Bill O'Neill, Greg Stone, Dan Burkhoff is well known in shock circles. I think he's an anesthesiologist, but really a cardiac anesthesiologist. And I point that out to say that this is a solid, approved treatment that is FDA approved, even though I think many of us have not until recently heard of it. This is the central illustration from that article, and it focuses on where we were in the past. So what is this no reflow phenomenon? It has to do with edema of the capillaries and sludging in the capillaries. The supersaturated or SSO2 concept here, and we'll discuss this in greater detail. And then preclinical studies really showing the benefit, at least in a preclinical setting, of SSO2 treatment. And they showed evidence of decreased endothelial swelling, increased coronary blood flow, decreased infarct size, and a sort of squashing of free radicals, which can be deleterious to myocytes. And then the clinical studies, the acute MI hot and the icy hot trials, which showed decrease in infarct size, which, as we'll see, correlates to improvement in heart failure and reduced hospitalizations. And then far off on the right side, you see the FDA approval in 2019. So let's spend a minute just looking at what this looks like. So this is the console for this device. It sits in the room. It can move from room to room. After you've done your PCI, the patient has gotten this stent, the vessel is open. So, for those of you who do interventional cardiology, so the temperature in the room has decreased. We can breathe a sigh of relief. Most of the work is done. Then we introduce a special catheter. It's a 7 French. So for context, most of the times we do interventions through a 6 French catheter. So we do use a slightly larger catheter that allows removal of blood from the patient's own circulation. Then it gets super saturated with oxygen to a PO2 target of 1,000 millimeters of mercury, so 9 to 10 times above normal. And then it gets reinfused, not just into the body, but into the coronary artery through a special 5 French catheter. And again, to give context to those not commonly in the cath lab, 5 French is a little bit smaller than the usual catheter, which is 6 French. And that's important because it gives you comfort that it's not a big bulky catheter that's likely to cause damage when you're infusing. And then the infusion takes 60 minutes. In that time, the operator can be speaking to the family, charting, doing his or her report. Obviously, the nurse and the technologist remain in the room. And as I say, the bulk of the work is done. Then we remove the catheter, we close the groin, however we do that, and we move on. So that's the process. As those of you who work in the cath lab, adding another hour at the end of a case, especially if it happens to be in the middle of the night, isn't always your preferred thing, but having done it now at the Institute more than 10 times, and we only started this in May of 2021, it really has become very commonplace and sort of expected. And I think it's going to become a part of the standard practice, again, for anterior MIs with early presentation. So it's important that we use these devices in the way that they were studied. So it's not currently for circumflex or the right coronary or delayed presentations of STEMIs. We touched on this already, and I think there's another graph that shows this. So I'm going to move forward here. So this highlights again the microvascular obstruction caused by 2 things: the swelling or the edema of the capillaries, the activation of neutrophils, and just the sludging of blood. And with the SSO2 therapy, supersaturated oxygen, we see decrease in edema, and we see the easier egress of oxygen from the plasma into the myocytes. And that has 2 effects. It reduces myocyte death, and it also then, by improving the edema allows more red blood cells to get to the tissue. And the mechanisms by which this ultimately reduces infarct size, so increased oxygen delivery by plasma to viable tissue, decreases microvascular damage, reducing inflammation, reducing reactive oxygen species, increasing regional blood flow, improving metabolism, and ultimately the proof of the pudding is it decreases infarct size and programmed cell death. And ultimately what we see on our echoes would be less LV dilatation and less LV remodeling. Some of the clinical studies are shown here, and we're not going to go through them in detail, except to say that, you know, it's not huge numbers of patients, but enough that we have good data. So the acute MI hyperoxemic therapy, that's the AMI-HOT 1 and 2 trials. Notice on the right here that they were first looking at all comers within 24 hours, and we weren't seeing much benefit. So the second iteration of this was anterior MI within 6 hours, and there we started to see benefit. And then the IC-HOT intracoronary hyperoxemic therapy was the sort of the FDA guided trial that was able to let this come to market. This looked at 100 patients and within 6 hours with an anterior MI. So some of the data are shown here. And what we're looking at is infarct size. And in all of these trials, we see a decrease compared to control in the infarct size, and ultimately achieving a 6.5% absolute infarct size reduction. We've already said that 5% cutoff is what we shoot for, at least as a level of infarct size reduction that should yield improvements in outcomes, long-term improvement in EF, decreased heart failure, and decreased heart failure hospitalizations. What we're seeing here is that the most benefit is gotten the earlier you get patients to this treatment. So in this middle bar here in the green, we see a 41% reduction in infarct size for anterior MIs treated within 3 hours. This is looking at decrease in LV dilatation, or conversely, improved LV function from 2 studies, including the IC-HOT trial on the right. And here we're just looking again at the IC-HOT. It was 100 patients, and they looked at what we call net adverse net adverse clinical events, and they compared it, or they benchmarked it against an objective performance criteria, an OPC. Well, what would we expect the NACE rate to be in a standardly treated population? So that number that we were shooting for was under 10.7, and we measured the infarct size by MRI at days 4 and 30. And what we see was basically a composite NACE of 7.1%, well below the OPC of 10.7%. And as you might expect, the biggest adverse event was a slight increase in bleeding at the groin, because we're using slightly bigger catheters for a longer time than usual. In this particular set of patients, there were 0% death or new onset heart failure in the treated patients, compared with a rate of 12.3% in the not treated patients. And by not treated, they of course had their PCI and their standard therapies. They were not treated with SSO2, with the oxygen therapy. And not to belabor this point, but reducing infarct size correlates to improved mortality and less heart failure. And this is why we are passionate about this and why we think this matters. So to summarize, SSO2 really is the next step in the treatment of STEMI. It significantly reduces infarct size post-MI. It reduces, or restores rather, microvascular flow, and now is supported by at least 3 FDA-sanctioned clinical trials. And really reducing the amount of infarct is the way we save more hearts and improve long-term outcomes. So we are really excited to be really one of the few centers, I believe, certainly in Florida, and one of many, but not an enormous number, even in the US, to have embraced this and are offering it now to our patients. So I want to pivot to just introduce the team here for 2 reasons, because they're great, but perhaps more important to help us realize that the care of patients and the bringing to bear of guideline-directed treatments and innovations really is a team approach. And long gone are the days where it would just be one doctor who would see the patients in the office, and they go do their case, and they see them a few days here in the hospital, and they follow them in the office afterwards. And that model works, but it doesn't let the involvement of multiple people who can bring different levels of expertise and different focuses of care. So on the right, you see the interventional cardiologist. Two of us are structuralists, Dr. Lopez Sanabria and Dr. Quesada. And what that means that in addition to doing interventional cardiology, i.e. stents, acute MI treatment, chronic total occlusion interventions, they also do cases such as transcatheter aortic valve replacements, mitral clips, ASD closures, and other things like that, which are even more multidisciplinary in nature. And that certainly would be another talk, maybe for one of them to give at another time. And the rest of us, Dr. Gomez, Dr. Lorette, and myself, are coronary interventionalists. On this side of the screen, we see a number of other folks who are very important to our process. We have a nurse navigator, Monica. She's important in helping patients get to the lab, helping them get scheduled, communicating with outpatient offices, making sure that people are getting the records that they need. And she also helps organize our schedules, so she knows who's doing what and when, and can often be the one who assigns cases during the day. And then the remainder are the advanced practitioners, the APPs, sometimes more commonly known as PAs or nurse practitioners. And they do a variety of things, but they help get their patients ready for procedures. They care for them before and after. Jeff, who's seen here on the right, he runs our APP post-PCI clinic. So once someone has had an intervention, really that first visit right afterwards is very important to assess the access site, to ensure understanding of the issues, and to ensure compliance. And by having a dedicated APP clinic, they can always be seen very quickly without waiting to get into the busy physician's schedule. So a great team, and one that we're working on, but it's definitely a team sport. So let's move to another case. This is a 75-year-old gentleman, and this will highlight another thing that we're very proud of, which is our heart team. This gentleman had a long history of coronary disease. He had underwent bypass surgery in the 1990s. Subsequent to that, had a PTCA, just a balloon angioplasty. I don't even think there were stents back then. Ultimately got a defibrillator, had significant ventricular tachycardia, and a severe cardiomyopathy, his ejection fraction 10 to 15%. He had been on the transplant list for a heart transplant in the early 2000s. And he said to me that he got off the list because all of his friends on the list were dying, which it sort of made me chuckle that he realized that transplant for him may not be the best option. Anyway, he survived and is surviving, presented to us for the first time in early 2020 when he passed out, had 2 episodes of syncope. Again, if we were more interactive, I'd pause here and ask the students, well, what concerns you for someone with this history and syncope? And many of you would have said, well, ventricular tachycardia. And we had a built-in way of checking what caused his syncope because he had a defibrillator, and did in fact show that he had VT. It was treated initially with what we call ATP, anti-tachycardia pacing. That's where you try to pace the ventricle faster than the VT. And that didn't work in his case, and he got shocked, which I'm told is a sensation that feels like being kicked in the chest by a horse. So it's not a pleasant thing. So even though that is what defibrillators are for, and it saved his life, we always work to reduce the frequency of shocks, either with medication or fine-tuning the defibrillator itself. So in his case, he didn't have a troponin elevation. He really didn't have symptoms of angina. He was loaded with an antiarrhythmic amiodarone. And we talked amongst ourselves, well, what should we do next? Are we obligated to do a catheterization or any type of ischemic workup? We ultimately decided, in discussions with everyone, to cath him. He had, as I'll show you in a second, a significant lesion in the circumflex vessel. This is a still picture of his heart, so we can't see it squeezing, but what you can appreciate, or what I'll point out to you, is how huge his ventricle is. So his left ventricular end diastolic dimension is 7.27 centimeters. Normal is 5.6 or 5.8 or less. So it's a hugely dilated ventricle, a perfect substrate for VT. So he ultimately underwent stress testing, which showed no ischemia. We did cath him. He had some disease, but it was complex. We said, unless he's ischemic in that territory, we're not going to do anything else. Why make things harder than they need to be? He was discharged home on guideline-directed therapy. But at outpatient follow-up, both with the heart failure specialist and his clinical cardiologist, he did start to complain of dyspnea on exertion and occasional chest pain. So we decided that he should be evaluated for PCI, percutaneous coronary intervention. This is a picture, again, these are still pictures of his coronaries, but a very tight blockage here. This is the left main into the circumflex, tight blockage, 99%. In this view here on the right, we can see a calcified shadow of what used to be his LAD, but no flow is going in that direction. And then these are views of injections into his left internal mammary artery. So that's anastomosing to the LAD. There's antegrade flow and retrograde flow and filling of the septal perforator. So really just an amazing demonstration of the longevity of the lima. I mean, this was done in 1992, and in 2021, I think that's what, 20 years later, still going strong. And this is the reason why he's still alive. So this is a nice segue into talking a little bit about the heart team. And so CHIP stands for complex high risk indicated PCI, and protected PCI just means doing percutaneous coronary intervention with the support of some type of ventricular assist device. And that might be necessary when people are at risk for hemodynamic compromise or decompensation, quite frankly, during PCI. So as you would imagine, during PCI, we inflate balloons, we occlude blood flow, sometimes we spark arrhythmias, and a weak ventricle or a person with multiple comorbidities may not be able to tolerate that. And what we would do in the old days, meaning before protected PCI was a thing, we would sort of hit them hard with blood pressure medicines. We would work quickly, rush through the case. And both those things had adverse effects. So these days, we have the option of doing procedures with the support of an intra-aortic balloon pump or another type of ventricular assist device called an Impella. But most important is the heart team evaluation. So heart team used to mean just the interventional cardiologist talking with the heart surgeon. We've now evolved to where we have a formalized process. They're scheduled meetings, but we can also have ad hoc meetings where there are representatives by Zoom or in person with imaging, echocardiography, advanced heart failure, surgeons, interventional cardiologists, and cardiologists. And it really has blossomed into a great productive forum to do the very best for patients. Sometimes the discussions lead us to realize that there's nothing more that we can offer this patient, or it leads us away from one technique into another. We developed and sort of formalized our heart team process actually during the pandemic of all things. And it really has blossomed into a great addition to the menu of service that we offer our patients. These are some of the left ventricular mechanical support devices. We will not go through them in detail. The intra-aortic balloon pump and the Impella are the two that are most commonly used at MCVI. We also have access to the tandem heart and ECMO, but we're not going to discuss that right now. The intra-aortic balloon pump should be well known to most of you, especially those specifically in medicine, but it inflates in diastole. So it sort of pushes the blood, it sits in the aorta and sort of pushes blood into the coronaries during diastole when they are doing most of their filling, and modestly also increases aortic pressure. And those two things improve coronary flow and oxygen supply to the heart. The Impella sits in the left ventricle. It extracts blood from the ventricle, thereby reducing the ventricular size and taking the pressure off of the ventricle, at least in terms of the subendocardium. So it unloads the ventricle, that's the term that we use, and then it expels the blood into the LV outflow tract, so it increases systemic blood flow. So it does two very important things, and in so doing, improves cardiac power output, improves oxygen supply, and reduces oxygen demand in the myocardium. This is an example, not of our patient, but in a PCI in someone without support who is at high risk, what we might see when we do those inflations is that the blood pressure drops and things get very dicey for the patient. With the Impella in place, we see an initial drop in blood pressure, but then we see a stabilization. And this gives the operator the luxury and the time to carefully do his or her work. So in our patient, we've decided to proceed with an Impella-supported, IVUS-guided intravascular ultrasound, rotational atherectomy, so we're dealing with calcium, also cutting wound atherectomy, intravascular lithotripsy, DES, drug-eluting stent implant. So a whole bunch of very complex things all in one case, all with the aim of improving outcomes, getting a good procedural outcome, but more importantly, getting him back to his life without symptoms. So briefly, this is the impella in the left ventricle, similar to what we saw in the cartoon. These are sternal wires. Right here on the top right is the burr of the rotational atherectomy device, and you'll see that in a second. This is the tight lesion that we saw, the before, and here you see a very lovely result, the after, and we have those branches of the circumflex. I'm going to go briefly into rotational atherectomy because it's not the main focus, but calcium is a problem. It makes it hard to deliver stents. It makes it hard to adequately expand stents. It could sometimes lead to procedure failure. And even if you get through the procedure, it leads to worse outcomes. So how we deal with calcium is important, and it's a challenge that interventionalists face. One of the things that we use is rotational atherectomy, which uses a diamond-studded burr that rotates at high speed, and it sort of ablates calcium in its way. And it operates on two mechanisms. One is the concept of orthogonal displacement of friction, and that's best explained by the action of uncorking a screw out of a cork out of a wine bottle. So that rotational motion reduces friction, so it lets you get through the lesion, whereas you might not have been able to get a balloon through it or something like that. And then the other concept is that of differential cutting. And here we think of when we're shaving, we're cutting the stubbly here, but not the healthy skin. Similarly, the rotational atherectomy will ablate calcium, so diseased endothelium, but it generally does not harm healthy vessels. The next one, and this is new, is something called intravascular lithotripsy. So lithotripsy is well known, I think, to most of you as a potential treatment for kidney stones. So it's really shock waves that dissolve or break up the calcium. This technology has been used also in the peripheral artery world for iliac disease and lower extremity disease, but only until fairly recently has it gained traction in the coronary space. And I think it was only until 2021 that we have started doing intravascular lithotripsy in coronaries. This is some of the data, but it is easier for me to show you this in a quick video from the company. The company is called Shockwave, but the process is intravascular lithotripsy. And let me go back there, guys, and see if I can play this. You're still hearing it, Dr. Hakim?
The Shockwave intravascular lithotripsy system creates pulsatile sonic pressure waves to modify calcium in a safe manner. It consists of a compact rechargeable generator, a simple connector cable, and an intuitive catheter, which houses an array of lithotripsy emitters enclosed in an integrated balloon. Through the localized delivery of lithotripsy, the IVL system minimizes trauma, optimizes outcomes, and simplifies procedures. In a standard technique, the IVL catheter is advanced and placed at the lesion using marker bands under angiography, with the integrated balloon expanded to subnominal pressure of 4 atmospheres by a mixed saline and contrast solution. The fluid within the fully opposed balloon acts as a coupler to facilitate efficient energy transfer of the sonic pressure waves into the vessel wall to reach the calcium. The generator produces 3 kilovolts of energy that travels through the connector cable and catheter to the lithotripsy emitters once per second. While other treatments can't differentiate between calcium and soft tissue, acoustic pressure waves pass through soft tissue to impact both intimal and medial calcium. With emitters along the length of the balloon, a localized field effect is created. A small electrical discharge at the emitters vaporizes the fluid within the balloon to create a rapidly expanding bubble that generates the sonic pressure waves and then collapses within a few microseconds. When the waves impact the calcium at nearly 50 atmospheres, they create a series of microfractures. After the calcium has been fractured and trauma to the surrounding soft tissue has been minimized, the vessel becomes more compliant. Once lithotripsy has been completed, the operator can proceed with the preferred treatment strategy to optimize outcomes.
So one of the main studies that sort of brought lithotripsy with respect to coronaries is the Disrupt CAD3 study. Looked at 431 patients, and basically they show that coronary IVL safely and effectively facilitates stent implantation in severely calcified lesions. And in fact, at the TCT meeting starting tomorrow, I believe, in Orlando, Transcatheter Therapeutics, which is really the biggest interventional meeting, the 1-year data for Disrupt CAD3 is going to be released. And what we're hoping is that we see sustained freedom from MACE, and that will be an interesting thing. So again, another example of technology that even a year ago, if we gave this talk, we weren't doing. And I think the pace of innovation and the ability to embrace it is one of the things that I think will continue to set us apart. This was some slides that I got from my colleague, Dr. Gomez, and we're going to transition here to robotic intervention as another example of how things have evolved. So PCI, when you think about it, involves an operator standing at the side of a bed, gaining access. So this picture here is of Dr. Andreas Krunzig during the first procedure in 1977. Fast forward to 2017, and it looks a whole lot the same. An operator getting radiation, standing in lead at the side of the bed. A lot has changed, of course. That operator now can give put stents in, is potentially using ventricular assist devices. Most of us, including at the Institute, have a default strategy of radial artery access over femoral access, but some of the logistics really are still the same. And this is where robotic treatment comes into place. It is the leader in this field is a company called Corindus. They have recently been acquired by Siemens. But the goal is to let the use of robotic technology and ultimately perhaps even artificial intelligence guide and facilitate coronary interventions. Again, this is supported by clinical data that shows very high rates of procedural and device technical success, and huge reductions in radiation exposure to the operator. So if you can sit in a shielded console, many feet away from the patient, or ultimately even remotely, then your radiation risk is going to be a lot less. So MCVI had the first of the second generation of the robotic arm. And as I said, my partner, Dr. Gomez, has been one of the leaders in this field. Let's take a quick look at what some of the advantages of robotic PCI. So on the left here, you see traditional angiography, and this really literally reminds me of me this morning. You're on the patient's side and you're craning your neck over to see the screen and making these millimeter movements and decisions. So this is to those of us who do angiography, this is a very common occurrence. So we're struggling to see, and we're making small movements that are very important. We're eyeballing lengths to make our decisions regarding the stent. Plus we're standing in lead, we're getting a lot of radiation and a lot of orthopedic fatigue. With robotic assisted PCI, you can sit comfortably at a console. You're still in the room, although you don't need to be for sure. You can make millimeter at a time adjustments using a joystick, not your hands pushing. You're shielded from radiation and you're not wearing lead. So it really is potentially a win-win. These are the joysticks that you see here. This is Dr. Gomez doing a case, and this is him from a different point of view. So he is still very close to the action, and when needed can jump back into scrub. There are always nurses and techs, including a scrub tech who is scrubbed there. So the patient is not abandoned, but this enables us to do more careful, precise work that might lead to reductions in stent usage if we choose the right length to begin with, and also an option for complex PCI. Reduction in risks of orthopedic challenges, great reductions in radiation to the physician, but also the scrub tech is able to be a bit further away from the action. So he or she will also get less radiation. and reduce radiation to the patient, perhaps through the reduction in overall procedure length because of improved visualization and some degree of precision with ballooning and stenting. So this we started over 4 years ago. We took a real long pause with the pandemic, but have started back again. So over 100 cases so far, and we'll see where this takes us. I think it still has a fair way to go to really become commonplace, and it may have some ultimate ramifications in the field of tele-intervention. So you could have an operator sitting in one place and guiding an intervention in another place where maybe there isn't an interventional cardiologist, but a general cardiologist who is able to do catheterization, but not PCI. But a lot still to do. This is the last set of slides, and this literally came to my attention, I think, just 2 days ago. But it's a device called Experience Medical Virtual Presence. It's from ImageStream. I think they were recently bought out and now are called Olympus. But it is a way of improving virtual collaboration. So you have a cath lab, you have an operator, an interventional radiologist, an interventional cardiologist who wants to share their information with either a classroom or a colleague for a consult. And how do you do that? So those of you who have ever been to MCVI, it is a very transparent sort of cath lab, and the whole community is one of, we're here to help each other. But people aren't always around. It might be the middle of the night, or people may be elsewhere. So how do you get information from your cath lab, maybe to a colleague that you want to run something by? And this is a potential solution for that, where we have in the lab a integration of software and hardware that we can show a user on the other end, someone in a classroom, at an offsite location on a desktop or a handheld, what's going on. So you can interact with them, they can see what you're seeing. So we haven't really even started to use this yet, but I think this is going to be another game changer in the way we afford team care to patients. So we'll keep moving through that here. So stay tuned. One of the applications that I can see already for this type of technology, so we have a shock team at MCVI, which is where when someone is very sick, they've gone into shock, most commonly acute MI complicated by cardiogenic shock, they need a balloon pump, maybe an Impella device, which you've heard about. Very often what happens next is difficult to decide. So patients may not be doing well on that treatment, and we need to get input from a lot of specialists all at once: anesthesiologist, the advanced heart failure specialist, the cardiothoracic surgeons. So we developed a process where with one phone call, we can get all those people on the phone and talk about the patient and make a decision. Do they need to be escalated to ECMO? Do they need to be transferred to a heart transplant center? Are they good enough to just sit tight? And I think this virtual presence is going to be another game changer, where not only get them on the phone, but everyone all at once can see what's going on. They can look at the hemodynamics, they can look at the coronaries. So stay tuned for that. So I hope that this presentation gave you a sense of some of the innovations that we are lucky to be using at MCVI. When I think about it, the two things that I talked about the most, the SSO2 and the shockwave therapy, even if we were having this conference in December, we wouldn't be talking about them. And the pace of moving forward of interventional cardiology, but as importantly, the pace of our ability to integrate these things into our practice at MCVI, to me, are staggering. And I think this is one of the things that sets us apart, because yes, it's one thing to know the data and to understand all of these in concepts, but to be part of a team and a hospital and an administration that gives you the tools that you need to do your job, I think is amazing. And then the other thing I want you to take away from this is that this is no one man or woman who can do this alone. There's no one in the universe who can know everything and know everything well enough to treat these very complex patients. And having a process and a system in place where we can easily facilitate all of the relevant people getting to give input for the benefit of the patient is something that is very gratifying. So I'm sorry I wasn't able to interact with you all. I hope with Dr. Hakim's input, we can do some questions, but it was a pleasure to talk to you. Thank you.
The pleasure was all ours, Dr. St. John. Always, always such a pleasure listening to you, because the breadth and wealth of knowledge that you bring to the audience, always it's well received. Wow, I mean, incredible accomplishments at MCVI, incredible accomplishments by your team. It is just remarkable, and it fills us with pride and joy to know that our patients and ourselves are in great hands with great technology. MCVI has distinguished itself for many years now, ever since the inception 30 or 40 years ago, of being at the forefront of technology. And you guys have brought the greatest and best physicians into your team, and these incredible machineries and armamentariums that you have to treat patients. It is simply remarkable. I am in awe simply because I know how important this is to the entire medical community, but more importantly, how advanced and how fast things are evolving in cardiovascular and interventional radiology and so on. SSO2 therapy after PCI plus stenting will become a standard in the future. Wow. I mean, what was the ways of actually doing this in order for us to make certain that the patient really responds to a treatment? Because obviously the technology has not necessarily been already in place in some countries. So we're still dealing with patients abroad, and they're doing a phenomenal job in treating them. But this is just an added bonus. So what are we still doing that is perhaps the old way that would be similar to the outcomes done by SSO2 therapy?
Yeah, so I think it's very important to realize that you have to do the very best in the context in which you are. And this is not by any means going to be something that is going to be readily available to everyone. So in certain parts of the world, and quite frankly, in certain parts of this country, early thrombolytic therapy is the way to go. And that is going to improve outcomes for a majority of patients. The most important takeaway, I think, is to focus on making sure you have a process in place for these types of patients so that you can avail them in a very predictable, uniform fashion of the very best that you have to offer. And that usually involves having guidelines. So it doesn't matter who's on call or what time of day it is. You come in with a STEMI, let's say in rural Mississippi to pick a place. Maybe you don't have a cath lab. Well, we're going to get your door to needle time be 30 minutes. So doing the very best you can with what you have, and then escalating to the next level of care where feasible. So for many of us, it's primary PCI. And again, that does an amazing job. So no one should leave here with guilt that they don't have SSO2 therapy, but this may be the next step, the icing on the cake that shows us a little bit of reduction in those long-term events of heart failure and hospitalizations with heart failure that have plateaued. So without any therapy, we're looking at early death, early heart failure in a lot of patients. With standard of care, much less, and then maybe with SSO2, even less. But I acknowledge that this will not be something that is going to be able to spread like wildfire because it involves expensive technology. And I think people need to organize themselves into teams and have processes that make sure that you're doing the very best with things that are accessible. And we each have a lot of opportunities to do that, making sure that patients can access affordable medication. That's going to have a much greater impact than the additional, the definite and incremental benefit of SSO2, but I think just doing the best with what you have available is the most important lesson here.
We agree, and I will paraphrase one of the pearls I take from you, which is decrease mortality by decreasing the infarct size is definitely the ultimate goal.
Yes.
So whichever way, whichever means that you're currently doing it, you and our peers abroad, it is definitely a plus. some kind of a win, at least for the patient. It does strike me as something that we really need to emphasize, and it's the fact that in this particular type of work, you need an interdisciplinary team approach. And that is exactly what you have established at MCVI. And that is what you're trying to share with others, how important it is to actually have a team similar to what the stroke victim will undergo with the rapid response team and the time from identification from the emergency room to the MCVI lab. It is extremely important to enable the team to determine if the patient can actually be a candidate for this type of procedure. You did mention that you have a 30-minute standard time from ER to OR, or
not well. We aim for under 60 minutes. So the guidelines encourage under 90 minutes, which we get almost 100% of the times. And then ultimately in under 60 minutes, not uncommonly do we have patients in the lab with the artery open in 27, 25 minutes. And those goals are really from time of first onset of symptoms would be even more ideal. And some of that though is out of our hands, and that's where public education and public service announcements become important. So when people are taught to recognize the symptoms of a heart attack, they don't dilly-dally and they get to medical attention. But the goal is door to balloon time in under 90 minutes, and most commonly in our institution, it's under 60 minutes.
That's remarkable. But anyway, we have some questions before we let you go, Dr. St. John. Let's see if we can answer some of them. Dr. Mermelstein, I don't know where she's from, but she is asking or saying, very interesting presentation. I'm a healthcare provider, but not a cardiologist. I have two questions. Are the microvascular vessels damaged due to the low blood flow due to the blockage in general, or only if there was an MI? And two, can this procedure be applied in patients who had a stent placement or bypass surgery years ago?
Well, I'll take the second part first. So it's not really approved or likely to be helpful in someone with distant coronary disease, because that is a context in which is unlikely to be acute microvascular obstruction or no reflow. Those patients can still have endothelial dysfunction, but that has not yet been studied nor approved. The cause of no reflow or microvascular dysfunction is still to some extent not 100% well understood, but when the flow is cut off, it does lead to cell death. But we think the mechanism of the no reflow or the microvascular obstruction, once we have restored the epicardial blood flow, is from that edema, that swelling of the capillaries themselves, the activation of neutrophils, and the clogging of the capillaries with red blood cells. So it's multifactorial, but it's edema of the capillaries and clotting of blood in the capillaries themselves.
You have several admirers here, but we have Anna Basil that says, Dr. St. John, great to see you. Can IPL be used for coronary artery intervention as well? Well, Anna Basil, she adores you.
I adore Anna. So I don't think it's yet been studied for carotid intervention. I could be wrong, but I think in terms of the peripheral artery use of IVL, it's only in the lower extremities, the iliacs in particular. I know we've used a lot with some of our large bore interventions, so that I'm aware, not yet used in the carotids.
Mm-hmm. So similarly to what you do with the lithotripsy, it's for a lower extremity type approach. Ana Catalina is from Costa Rica, and she says, thank you for the information shared. It makes MCVI different and innovative. Does SSO2 have benefits in patients that had infarcts weeks or months or years prior to the treatment?
So similar to the earlier question, the answer is probably not, hasn't been studied, but the pathophysiology of the microvascular obstruction really is almost always in the setting of an acute event. So it would make that unlikely. There may be other similar therapies, and certainly people are studying stem cell injections and other things for scar in myocardium and in scar diseased hearts. But the short answer is no, and certainly the even shorter answer is it hasn't yet been approved for that. So we wouldn't be doing that currently.
All right, we have a question from Mr. Handal, and it says, when is it time for practicing such procedure in the costing proceeding? There is a previous test to find, is there a previous test to find out how much calcium do I have in the arteries? Can one have the video for the, sorry for my English. It's okay, Mr. Handal. Thank you so much for your question.
The English was perfect. So I think what the question is asking is, can you know ahead of time how calcified the vessels are? And the short answer is probably, although sometimes you're meeting someone for the first time in an acute setting and you may not have the luxury of previous testing. Many times these days, patients have gotten a coronary CT angiogram, which can give us very precise quantifications of the calcium burden. That's number one. Number two, sometimes we can see calcium on just a chest CT done for other reasons. And then number three is sometimes when we are faced with these complex interventions, especially if the patient is stable, we just do a diagnostic cath. So we get information, then we hit the pause button, we end the procedure, we talk with our heart team and come up with the best strategy. So that really is the best case scenario, to have a lot of information as he's suggesting, so that you can go into a procedure as well prepared as possible.
That's wonderful. Mr. Elliott has a question. Can SSO2 be helpful for persons with chronic stable angina?
I think that is not Mr. Elliott. That's my good friend, Dr. Victor Elliott.
That's Dr. Elliott. Okay.
It's good to see you there, Victor. I think the short answer is not yet studied. So we don't know. Again, it is focused on relieving microvascular obstruction, which may not be the pathophysiology of chronic stable angina, but it does raise the possibility of trying to think outside the box and how to treat those very difficult patients as well.
Wow, Dr. St. John, this is a phenomenal presentation. I can't wait to do it again in some conferences in the future. We can't wait to travel to all these fine people's countries in order for us to be present with them. But we're going to let you go. We know how busy you are at MCVI, so we thank you for your time. And on behalf of our international team, again, thank you so much for that incredible presentation. And to all of you for attending and participating in today's conference. If you have any additional questions about today's presentations, please feel free to email them to BHIWebinars@baptisthealth.net. We will make sure to forward those questions to Dr. St. John for him to respond and send back to you. We look forward to seeing you at our next Cardiac and Vascular Lecture Series scheduled for February 2nd, 2022. Thank you once again. Stay safe and have a phenomenal afternoon. Thank you, Dr. St. John.
Appreciate it.